Hello, my name is Stephen Lester, and I'm a consultant cardiologist at the Mayo Clinic in Arizona. And it's really an honor and a privilege for me to have the opportunity to discuss with you some of my thoughts on the echocardiographic evaluation of left ventricular diastolic function, or more specifically, the physiologic consequences of abnormal diastolic function, the elevation in left ventricular filling pressure. I have no relevant financial relationships with which to disclose. Now, echocardiography is a powerful tool that may provide the key to help unlock many of the mysteries of diastole. And although there are a number of different echocardiographic parameters that can be obtained and their values integrated to help characterize LV diastolic function, or again, more specifically, the physiologic consequences of abnormal diastolic function, the elevation in LV filling pressure, what I would like to propose is that in general, there are three key echocardiographic measurements that we can use in daily practice. And these are: 1, a volume-based measure of left atrial size; 2, to look at blood flow velocities, in particular the mitral inflow velocity profile; and 3, a measure of left ventricular function. These measures then shape this key, which can be used to fit the lock. So key measurement number 1 is this volume-based measure of left atrial size. This is key measurement number 1 because for the most part this gives us insights into the chronicity of elevation in LV filling pressure, and 2, helps to characterize global cardiovascular risk. Key measurement number 2 is to look at blood flow velocity profiles, in particular the mitral inflow velocity profile, characterized by the amplitude of the E wave, the A wave, and the E wave deceleration time. And key measurement number 3 is to look at left ventricular function. We look at global LV function. Is the ejection fraction normal or reduced? And then, in particular, in those with a normal left ventricular ejection fraction, using Doppler tissue imaging, ventricular function may be characterized through the evaluation of myocardial velocities. In the evaluation of left ventricular filling pressure, we look primarily at the early diastolic mitral annular velocity, or E prime velocity, as this E prime velocity is a good indicator of myocardial relaxation, and LV myocardial relaxation is a very important component of diastolic function. So although there are other echocardiographic parameters that may be used to characterize diastology, it is these three which represent those which are commonly used in daily practice. And we are reminded that the measure of LA volume is perhaps the cornerstone to this evaluation, again for its ability, for the most part, to provide insights into the chronicity of elevation in LV filling pressures, but 2, to help characterize global cardiovascular risk. Now I'd like to share with you 2 cases. Both of these individuals presented with the clinical syndrome of heart failure. They both received therapeutic intervention. One remains symptomatic, and the other feels much better. Now, case number 1 is of a 62-year-old woman. She has COPD, being treated with Advair. She's had a long-standing history of hypertension and has noted a progressive decline in her renal function over the past 2 years. Here is her parasternal long-axis view, and we are reminded that it is often the initial observations of the two-dimensional image which can provide some diagnostic clues as to the status of diastolic function. Patients with diastolic dysfunction, qualitatively, you may appreciate that the LV walls are thick, that the left atrium is dilated, and that there is reduced annular motion. Here's the apical 4-chamber view: left ventricle, left atrium, biventricular ejection fraction is normal. Qualitatively, you may appreciate that the left atrium is dilated. For reasons, however, that I will allude to in a moment, I believe that it is important to go beyond a simple qualitative measure of left atrial size. And the Guidelines and Standards document from the American Society of Echocardiography on chamber quantification recommends that a volume-based measure of LA size be performed, and they recommend using either the biplane Simpson's method or, as illustrated here, the biplane area length method, where we look at the four-chamber view, we trace the area of the left atrium, being sure to avoid the confluences of the pulmonary vein, and then we measure the length. We look at the two-chamber view, we measure the area, being sure to avoid here the left atrial appendage, and then we measure the length. This formula is then used to calculate the left atrial volume, which is then indexed for body surface area. And although left atrial indexed volume is a continuous variable, there are proposed dichotomous cut points for mild, moderate, and severe LA enlargement, such that we not only characterize this parameter as normal or abnormal, but we begin to qualify the degree of abnormality. Recognize that not all echo parameters are qualified using the same methods. Most are based on a standard deviation above or below a reference limit from a healthy group of individuals. Some parameters, however, are too qualified based on expert opinion and or clinical risk, such as LV ejection fraction or left atrial volume. The point then being that an individual that has an LA indexed volume of, say, 39 mils per meter squared is of greater risk for an adverse cardiovascular event such as atrial fibrillation, heart attack, myocardial infarction, stroke, or dying than, say, an individual that has an LA indexed volume of 29 mils per meter squared. Now, as mentioned in the Guidelines and Standards document from the ASE, one may also use the biplane Simpson's method to calculate LA volume. The principle here is that the total LA volume is calculated from the sum of the volume of a series of stacked elliptical discs, where the cross-sectional area of each disc is based on the diameters obtained from the two and four-chamber views. What is important to recognize is that although the area length and Simpson's methods yield consistent values with each other at all ranges of LA volume, there are in fact differences in the values obtained by the two methods, such that the Simpson's method yields consistently lower values by about 3 to 4 mils per meter squared than those obtained by the area length method. As we look again at the proposed dichotomous cut points for mild, moderate, and severe LA enlargement, note that these are based on area length measurements, such that some translation in the discussion of LA volume measurements is likely required according to which method is adopted. Now, in our case number 1, we began with key measurement number 1, and we measured the LA volume by the area length method, and then indexed it to body surface area, giving us a value of 46 mils per meter squared. This is severely dilated. This tells us that in general, over time, LV filling pressures have been increased, and that this individual is at increased risk for an adverse cardiovascular event such as atrial fibrillation, heart failure, myocardial infarction, stroke, dying. However, what it does not tell us is what are the filling pressures at the instant in time of the evaluation. And so if the question is not what is the cumulative effect of LV filling pressure over time, but what are in fact the filling pressures at the instant in time of our evaluation, this involves integration of key measurement number 2, looking at blood flow velocities, with key measurement number 3, looking at ventricular function. We begin by looking at the mitral inflow velocity profile. Again, generally characterized by the amplitude of the E wave, the A wave, and the E wave deceleration time. Now sometimes you note that there is a nonlinear decay in the mitral E wave velocity. And when trying to evaluate for LV filling pressure, the question is, do we measure this initial slope in green or this second slope in red? And the answer is that when trying to evaluate for LV filling pressure, that we would measure this initial slope in green. And this is distinctly opposite from what we would do when, say, trying to measure the pressure half-time in an individual with mitral stenosis. And so here we see the amplitude of the E wave and the A wave and the E wave deceleration time of 183 milliseconds. Now there are a number of factors which affect LV diastolic properties and filling of the left ventricle. And it is really the interaction of all of these which reflect the diastolic transmitral pressure gradient, that which ultimately determines mitral inflow and the mitral inflow velocity pattern. Two important factors are left atrial pressure and the rate of relaxation of the left ventricle. If LA pressure remains the same, but the LV begins to relax more slowly, we will see a conformational change in the mitral inflow velocity profile, where the E wave velocity will decrease and the deceleration time will prolong. And now with reduced passive filling, there is a compensatory increase in the active phase of LV filling, or the A wave, in order to maintain stroke volume, as we see here. Now, as left atrial pressure rises, blood is getting forced into the LV at a higher pressure, the E wave velocity increases and the deceleration time shortens. As LA pressure rises again, blood is getting forced into the LV at even higher pressure, the E wave velocity increases, the deceleration time shortens, and now the contribution of active filling during atrial contraction is much less. So if we look at the natural history of diastolic function and LV filling, we appreciate that the mitral inflow velocity profile reflects the combined influence of impaired LV relaxation, this grade 1 pattern, and impaired LV relaxation with elevated filling pressure. Therefore, as one evolves from a pattern of LV relaxation through to one associated with marked elevation in filling pressure or a restrictive pattern, at some point in the middle, the mitral inflow velocity profile will look normal. Therefore, clinically, when one sees a normal mitral inflow velocity profile, we need to ask ourselves the question, is this truly normal and associated with normal LV filling pressure, or abnormal and associated with elevated filling pressure? Now, hemodynamic manipulation and its influence on the mitral inflow velocity pattern may therefore be useful to help further characterize LV filling, demonstrating again that the mitral inflow velocity patterns are really a dynamic continuum, with a pseudo-normal or grade 2 pattern during the strain phase of the Valsalva maneuver, which lowers left atrial pressure, may then unmask the underlying impaired LV relaxation. As shown here, this conformational change in the mitral inflow velocity profile during the strain phase of the Valsalva maneuver. Now, how do you know that the individual has in fact given an adequate effort? And the answer is that with an adequate effort, in those without a truly restrictive LV filling pattern, you would expect to see a decrease in the E wave velocity by about 20 centimeters per second. With a normal mitral inflow, you would see both the E wave and the A wave velocity decrease proportionally, with therefore an unchanged EA ratio. A decrease in greater than or equal to 50% in the EA ratio, with a noticeable increase in the A wave velocity and duration, as the atria are now ejecting into a ventricle with a lower pressure, can be quite specific for increased LV filling pressures. Recognize, however, that smaller values do not always indicate normal LV filling pressure. And in our lab, We do not routinely use this Valsalva maneuver, but for patients in whom the question still remains about LV filling pressure after looking at mitral inflow velocities and annular velocities. See, if we go back and look at the natural history of diastolic function in LV filling, we notice that almost universal to all individuals with abnormal diastolic function, perhaps aside from those with pericardial disease, that there is an abnormality in ventricular function, noted if not by EF, by the presence of reduced annular velocities characterized by the reduced E' velocity. So now, with impaired LV relaxation, not only do we see the expected conformational change in the mitral inflow velocity pattern, but too, the E' velocity decreases, as we see here. As LA pressure rises, the blood is being forced into the LV at a higher pressure, resulting in an increase in the E wave velocity and a reduction in deceleration time. But the E' velocity remains reduced. Therefore, one may think to look at the amplitude of the mitral E wave velocity in relationship to the amplitude of the E' velocity, giving us the so-called E over E' ratio, where we take the 0.09 divided by 0.04, giving us a value of 22, where in essence the E' velocities are being used to correct for the effect of LV relaxation on the mitral E wave velocity. Therefore, as LV filling pressure increases, the mitral E wave velocity increases, the annular E' velocity decreases, and the E over E' ratio increases. Now this schematic illustrates the principles behind pulse wave Doppler tissue imaging, where this here represents the high velocity but low intensity signal that comes from the blood pool, and this white bar here represents the relatively high intensity but low velocity signals that come from the wall. In spectral blood pool Doppler, this is considered noise in the signal, so we just simply turn wall filters on. In Doppler tissue imaging, that is in fact the signal that we are interested in. So to obtain this, we must simply turn the wall filters off, and now to get rid of what would be considered noise in the signal coming from the blood pool, we just simply turn down the gains, because the blood pool spectral Doppler is of much lower intensity. And here is an example of septal myocardial velocity tracings, where we see the systolic velocity towards the apex or transducer, the early diastolic mitral annular velocity or E' velocity, and the A' velocity. Now some important technical issues may center around gain settings. Because the wall signal is of much greater amplitude than that signal coming from the blood pool, it is important to be sure to turn down the receiver gains, or you may see blooming in the signal, making it difficult to discern truly where to measure this peak early diastolic mitral annular velocity. This is a Doppler-based technique, and therefore amplitude measures will be dependent on ensuring as parallel as possible an intercept angle with myocardial motion. And lastly, one must ask the individual to suspend respiration and expiration to ensure that the sample gate does not move off the region of interest due to translational motion resulting from respiration, causing this artifact and difficult to discern where to truly make these measurements. Now there are some limitations to the use of annular velocities. The E' velocity, for example, is generally reduced in those individuals with significant mitral annular calcification or mitral stenosis, individuals with surgical rings or valve prosthesis. E' velocity may in fact be increased in those with mitral regurgitation. and recognize that the E prime velocity is not an accurate index of LV filling pressure in those with constrictive pericarditis. Now, tissue Doppler of the mitral annulus is generally performed from the apical views, where the sample volume is positioned at or within the insertion site of the mitral valve leaflets, where here we get septal annular velocities. To then obtain the lateral annular velocities, we need to reposition the image to ensure as parallel as possible an intercept angle, with the sample volume then positioned at the insertion site of the mitral leaflet. And here we see the systolic velocities towards the apex or transducer, the early diastolic mitral annular velocity or E prime velocity, and here's the A prime velocity. Now here's our individual where we see the mitral inflow velocity profile. We see the lateral annular velocities with an E prime velocity of 18 centimeters per second and a medial annular velocity with an E prime velocity of 14 centimeters per second. And it is normal to see the medial annular velocity be less than the lateral annular velocity. Therefore, when obtaining the E over E prime ratio, do we use the medial annular velocity or the lateral annular velocity? And in fact, what the ASEUII recommends is in fact that we obtain both the medial and lateral E prime velocity and we average these, given the potential influence of regional function on these velocities. And when using an averaged E prime velocity, an E over E prime ratio greater than 13 is considered abnormal. A single site measure may be used perhaps in patients with globally normal or abnormal function. And if you use the medial E prime velocity, a value of over 15 has been considered abnormal. A lateral E prime velocity, a value of over 12 considered abnormal. But remember again, it may be imperative to average these in the presence of regional dysfunction. Now, not only can we look at the amplitude of the mitral E wave velocity to the amplitude of the E prime velocity, giving us this E over E prime ratio, one may also look at the relationship of timing of the onset of the mitral E wave velocity to the E prime velocity. You see, normally what happens is the ventricle relaxes first, and then blood gets sucked into the LV. If that's the case, then you would expect that the onset of the E prime velocity to occur a little bit before the onset of the mitral E wave velocity. If, however, what's happening is that left atrial pressure is high, blood is getting forced into the LV, and the annulus is secondarily coming back, then you might expect that the onset of the E velocity to occur at or before the onset of the E prime velocity. And in this individual with the clearly abnormal E over E prime ratio, this is exactly what we see, confirming the fact that this is associated with elevation in LV filling pressure. So in summary of this first case, we saw that the left atrium was enlarged. And this tells us that in general over time, LV filling pressures have been increased. The Doppler parameters, however, tell us that filling pressures remain increased at the instant and time of our evaluation, and this patient, despite our therapeutic intervention, remains symptomatic. Let's look again at case number 1. This is a 62-year-old woman. She has COPD. She's now New York Heart Association functionally class 3 with symptoms of shortness of breath, not responding to intensified treatment for her COPD. She's had a long-standing history of hypertension and noted a progressive decline in her renal function over the past 2 years. Now let's take a closer look at the echocardiogram. In this 4-chamber view, we recognize that not only is the left atrium dilated, but the right atrium is too quite dilated. We see that not only is the left ventricular wall thickness increased, but there's an increase in right ventricular wall thickness. So is this simply hypertensive heart disease? Well, the biventricular increase in wall thickness would be a little bit inconsistent. The biatrial enlargement, too, a little bit inconsistent. The right ventricular systolic pressure is only 38 millimeters of mercury, and recall there is an increase in RV wall thickness. We see a progressive decline in her renal function. Here is the 12-lead electrocardiogram, sinus rhythm, left axis deviation, perhaps slightly reduced voltage. And so this echocardiogram had features to suggest more than just hypertensive heart disease. In fact, it suggested some infiltrative process. This patient underwent biopsy and unfortunately had the diagnosis of cardiac amyloidosis. Now, although not directly reviewed in these cases, at some times it can be very informative to acquire additional information from the mitral inflow velocity profile, such as the isovolumic relaxation time, obtained with the continuous wave at Doppler in the LV outflow tract to simultaneously display the end of aortic ejection and the onset of mitral inflow. And if we look here at this Wigger's diagram, where we see arterial pressure, LV pressure, and atrial pressure, as atrial pressure increases, the time from aortic valve closure to mitral valve opening shortens, or the IVRT decreases. If we look at this echo, acquired from a 68-year-old gentleman, you note that although the LV ejection fraction is normal, the LA is severely dilated and there's significant annular calcification. When interpreting his mitral inflow velocity profile, we know clearly that the E wave velocity is significantly increased. And one must question whether this is secondary to MAC and some obstruction to mitral inflow, or if too, LV filling pressure is increased. Now, the relatively short isovolumic relaxation time and deceleration time would suggest that these findings are largely related to an elevation in LV filling pressure. At times, information gleaned from the pulmonary venous flow profile can be instructive. This is generally acquired from the apical four-chamber view, with color flow imaging helpful to guide the location for placement of a pulsed wave sample volume, which is generally about a half a centimeter into this right upper pulmonary vein, using a 2 to 3 millimeter sized gate. The velocity profile is characterized by a systolic and diastolic filling waves, along with an A wave reversal. Now, to optimize this signal, we have the patients suspend respiration and end expiration, and be sure to have the wall filter settings low enough so as to display the onset and termination of the atrial reversal velocity form. Now, as the systolic filling fraction decreases, pulmonary capillary wedge pressure increases, and a systolic filling fraction of less than 40% is related to a decrease in LA compliance and an increase in mean LA pressure. Note, however, the systolic filling fraction is of limited accuracy in individuals with an ejection fraction in excess of 50%. Now, when the atria contract, blood flow through the mitral valve into the left atrium. But there are no valves on the pulmonary veins, so as the atria contract, blood also flows back into the pulmonary veins. And we can see here that the onset of the pulmonary venous A wave reversal is the same as the onset of the mitral A wave inflow velocity profile. And similarly, we marked the termination of these two A wave velocity profiles at roughly the same time point. Now, left atrial size, the mitral inflow velocity pattern, these are indicative of an increase in mean LA pressure. Isolated increase in left ventricular end diastolic pressure is the first hemodynamic abnormality noted in those developing abnormal diastolic function. And when the pulmonary venous A wave duration exceeds the mitral A wave duration, This suggests an elevation in left ventricular end diastolic pressure. In general, a cut point in excess of 30 milliseconds is used. So unlike the systolic filling fraction, this temporal duration in A wave velocities remains accurate in patients with a normal left ventricular ejection fraction and is an age-independent indicator of left ventricular end diastolic pressure. Now, when we measure the mitral inflow velocity profile, we measure this with the sample volume at the mitral leaflet tips. When trying to measure the A-wave duration, we move this sample volume more to the annulus to get much clearer demarcation of the mitral A-wave duration. So we simply look at the mitral A-wave duration in relationship to this pulmonary A-wave duration. The difference here being 200 milliseconds, subtracting here 160, giving us a value of 40 milliseconds, suggesting that in this individual, again, left ventricular end diastolic pressure is increased. Now, case number 2 is of a 37-year-old gentleman evaluated for liver and renal transplantation. Here is the parasternal long axis view. The left ventricular ejection fraction is normal. Qualitatively, the wall thickness may be mildly increased, left atrium a little dilated, annular motion looks pretty normal. There is a small pericardial effusion. Well, we begin our evaluation by looking at left ventricular ejection fraction. Biventricular EF is normal, so global function is normal. And so we begin our evaluation for left ventricular filling pressure by key measurement number 1, this volume-based measure of LA size. We used the area length method, and we got a value of 32 mils per meter squared, telling us that in general, over time, left ventricular filling pressures have been increased, and that this individual may be at slightly increased risk for an adverse cardiovascular event such as atrial fibrillation, heart attack, heart failure, stroke, dying, than say an individual with a normal LA indexed volume. But what it does not tell us is what are the filling pressures at the instant in time of our evaluation. And for this, we begin with the evaluation of key measurement number 2, looking at the mitral inflow velocity profile, and integrating this with key measurement number 3, looking at our mitral annular velocities, or E prime velocity, giving us this E over E prime ratio, where we take the 60, we divide it by 11, giving us a value of 5.5, or quite low. So in summary, in this case, that the left atrium is enlarged, telling us that in general over time LV filling pressures have been increased. And our Doppler parameters, however, tell us that our filling pressures are in fact normal at the instant in time of our evaluation, so that this individual, with our therapeutic interventions, feels much better. If we take a closer look at this echocardiogram, we see that there's a very unusual appearance to the left ventricular myocardium. It looks very bright and white. And in fact, this individual had oxalosis, a very rare metabolic disorder with an autosomal recessive inheritance, resulting from an enzymatic defect with enhanced conversion of glyoxylate to poorly soluble oxalate, which is then excreted in the urine. One of my colleagues had labeled this a heart of stone. As we see in this image, the deposition of these crystals within the myocardium, giving it the appearance of stone. The diagnosis is through presence of hyperoxaluria and a liver biopsy. And we remind ourselves briefly that the management of our patients with the clinical syndrome of heart failure and a normal ejection fraction is not through general measures of ACE inhibitors and beta blockers and diuretics, but generally through the identification and targeting the specific etiology of the disorder. So if it's a valvular heart disease, we address the valvular heart disease. If it's ischemic heart disease, we manage myocardial ischemia. And in this case, it was through the management of his oxalosis, increasing the urine output, and generally through liver and renal transplantation. So we remind ourselves that echocardiography really stands alone beyond all other non-invasive imaging modalities for its unique ability to give us insights into cardiac morphology as well as into cardiac physiology. And when trying to evaluate for left ventricular diastolic function, or more specifically, the physiologic consequences of abnormal diastolic function, the elevation in LV filling pressure, although there are other echocardiographic parameters that may be used, it is these three which represent those which are commonly used in daily practice to unlock many of the mysteries. And we remind ourselves that it is this volume-based measure of LA size which may represent the cornerstone to the evaluation. Again, for its ability for the most part to give us insights into the chronicity of elevation in LV filling pressures, but two, to help characterize global cardiovascular risk. Now, another dilemma faced is what do we do with individuals who are in atrial fibrillation? And the answer is that we begin by looking at key measurement number 1, this volume-based measure of left atrial size. Now here's an individual with atrial fibrillation, and as we see qualitatively the left atrium is dilated. And one may say that by virtue of the electrical remodeling, there is two structural remodeling of the left atrium. And so does LA size continue to have clinical implications in those with atrial fibrillation? Well, if we flip the question around and think first to ourselves, who is at risk to develop atrial fibrillation, then it becomes clear that it's generally those who have an enlarged left atrium, as the age-adjusted cumulative survival free from non-valvular atrial fibrillation is very much influenced by a measure of left atrial size. So the fundamental question therefore becomes, who will develop an enlarged left atrium? And the answer to this fundamental question of who will develop an enlarged left atrium is generally those who have diastolic dysfunction, where LA size may be seen as the morphophysiologic expression of LV diastolic function. How does one develop an enlarged LA? Well, with decreased passive emptying, we have shown that there's a compensatory augmentation of active LA emptying. And this compensatory cascade functions to preserve stroke volume, but does set the stage for progressive structural and electrical remodeling of the LA, predisposing perhaps to atrial fibrillation. Now, the importance of LA volume is further underscored by the finding that the predictive value of who will develop atrial fibrillation is enhanced further by the addition of LA volume to a model that already includes clinical risk factors as well as some measures of diastolic function. So we recall these proposed dichotomous cut points for LA indexed volume, based somewhat on an individual's global cardiovascular risk. Does LA size continue to have an impact on risk prediction in those individuals with atrial fibrillation? Well, if we look at this paper, looking at factors affecting plasma BNP levels in patients with chronic AFib and a preserved LV ejection fraction, what is noted is that LA indexed volume remains an independent predictor of plasma BNP levels in these individuals with chronic AF and a normal LV ejection fraction. Now, if trying to evaluate filling pressures at the instant in time of evaluation, we're reminded that we need to begin by looking at key measurement number 2, this mitral inflow velocity profile. But of course, in those individuals with atrial fibrillation, there is no A wave. So we're left by looking at the E wave velocity and the deceleration time. Now, LV filling dynamics are very much dependent on the length of diastole, particularly when there's impaired LV relaxation. Therefore, with a shorter cycle length, ventricular filling depends more on a higher driving pressure, which will increase the E wave velocity. The opposite will occur with longer cycle lengths. Therefore, patients with high filling pressure will exhibit less cycle length variability in the amplitude of the E wave velocity. Therefore, the absence of a noticeable variation in the E wave velocity with cycle length should raise the suspicion of increased LV filling pressure and have you look more closely at more sensitive and specific findings. Now, since all LV filling must now occur without this atrial pump function, it has been commented that mean LA pressure and the peak E wave velocity are often slightly higher than normal for age, and the mitral deceleration time is generally a little shorter by about 20 milliseconds than in those with normal sinus rhythm. If so, these changes in E wave velocity and reduction in deceleration time are minimal. We note in this study those individuals in sinus rhythm in orange, atrial fibrillation in green, with similar BNP levels and ejection fraction, that there was no demonstrable change in the amplitude of the E wave velocity or the deceleration time. Now, if we come back to this individual who we showed at the beginning, who had a very large left atrium, and now we go and look at his mitral inflow velocity profile, we see that the E wave velocity is quite high at 130 centimeters per second, and the deceleration time is 143 milliseconds. When faced with an individual with an increase in the mitral E wave velocity, there are generally four possibilities for this. One, that this patient has mitral stenosis or some obstruction to inflow. Generally, you could address this through features on the two-dimensional image as well as a long deceleration time. Two, the patient may have an increased flow volume, such as with mitral regurgitation, but you would expect that in individuals with mitral regurgitation that the deceleration time would remain normal unless there's some underlying abnormal left ventricular function. Three, this patient may have a very high left atrial pressure, and so blood is being forced into the LV at a higher velocity. But in these individuals, you would expect a small E prime velocity and an increase in the E over E prime ratio. Or lastly, is very normal. Patient just relaxes very quickly, blood is getting sucked into the LV at a high velocity. But in these individuals, you would expect to see a large E prime velocity and a relatively normal E over E prime ratio. Here's our patient with an E wave velocity of 130 centimeters per second. We can also ask ourselves the question, what do we think is most likely the LVOT velocity? The point here being is since the E wave velocity and LVOT velocities are related to stroke volume and orifice area, a predictable ratio between these variables exists in normals regardless of heart rate and cardiac output. The normal LVOT velocity is say about 1 meter per second. Therefore, the mitral E wave to LVOT velocity ratio is about 80% in younger individuals, decreasing to 70% in the middle age, maybe 60% in the elderly, as LV relaxation slows and the E wave velocity decreases. A ratio lower than expected indicates impaired LV relaxation and normal mean LA pressure. And normal ratio with either increased or decreased EA velocities is seen with reduced or increased cardiac output. And higher than expected ratios indicate that the peak E wave velocity is increased, either due, as we said, to mitral stenosis or mitral regurgitation, or perhaps an elevation in left atrial pressure. And in this individual, we see the LVOT velocity is 0.8, the ratio is much higher than you would expect, suggesting again that this is secondary to an increase in filling pressure. In those with atrial fibrillation, one can also look at the IVRT, and as the IVRT shortens, is associated with an increase in pulmonary capillary wedge pressure, and a value of, say, less than 65 milliseconds has modest test characteristics with which to predict filling pressure elevation. One can also look at the pulmonary venous flow profile. We said earlier to look at the systolic filling fraction, which of course will be somewhat reduced or in patients with atrial fibrillation, since the S1 component is absent due to atrial relaxation. In individuals with atrial fibrillation, the systolic filling fraction too has some relationship to pulmonary capillary wedge pressure, as well as the rate of relaxation of the diastolic forward filling wave. We then said one must look at key measurement number 3. We said earlier that in patients with a normal ejection fraction using Doppler tissue imaging, we try to characterize these early diastolic mitral annular velocities. What we do note is that the correlation of tau with the time constant of LV relaxation with the E prime velocity is not significantly altered by the RR interval. The reduction in E prime velocity with the shorter RR interval appears to be more directly related to the transmitral pressure gradient, as the E velocity, therefore the E over E prime ratio, should still hold up in individuals with atrial fibrillation. So in our individual, we measured the E prime velocity of 0.08, and if we were to then calculate this E over E prime ratio, we would take the 1.3, we would divide it by 0.08, giving us a value of 16, which of course is elevated. We were reminded too to look at all other possible ancillary findings. Here this patient has an atrial septal communication. If we look at the Doppler velocity profile, we see that the velocity between the left atrium and the right atrium is close to 2 meters per second. So apply this to the modified Bernoulli equation. Gives us a gradient between the LA and the RA of about 16 millimeters of mercury. If we then add some estimation of RA pressure, suggests that the LA pressure is significantly elevated. We can look at the PA systolic pressure as well as diastolic pressures. Of course, looking at the right ventricular, assuming the TR velocity, as patients with diastolic dysfunction often have an increase in PA pressure. Therefore, in the absence of pulmonary disease, PA pressure may be used to infer the presence of an increase in LV filling pressure. If the patient has some pulmonary regurgitation, one can apply the modified Bernoulli equation to this end pulmonary regurgitant velocity to give us an estimate of the PA diastolic pressure, which has reasonable accuracy in estimations of LA pressure in those without moderate to severe pulmonary hypertension. So in our 78-year-old gentleman, he had a very large left atrium. His E wave velocity was significantly increased. The E velocity to LVOT ratio was higher than expected. The over E prime ratio was increased. Our ancillary findings all suggested that this individual had an increase in LV filling pressure. So when answering the question, how does one evaluate diastolic function in those with atrial fibrillation? The answer is generally the same as those who are in sinus rhythm. Lastly, we must remind ourselves that in this instance, atrial flutter is not the same as atrial fibrillation. Because in atrial flutter, regardless of whether there's 2 to 1, 3 to 1, 4 to 1, or higher block, really no assessment of LV diastolic function can be made from the mitral inflow velocity, as ostensibly all LV filling is influenced by atrial contraction. So our PA pressure calculation from the TR velocity may be the best indicator of increased LV filling pressure in the absence of lung disease. Perhaps similar comments can be made to those individuals with new onset or quote coarse end quote atrial fibrillation, which may resemble atrial flutter. So in general, again, echocardiography really stands alone in the field of non-invasive imaging based on its configurability and our ability to bring this imaging modality to the bedside, its unparalleled temporal resolution, the fact that it uses a harmless energy source, that it gives us unique insights not only into cardiac morphology, but as well into physiology. And again, when asked to evaluate for management or diastolic dysfunction, we're reminded again that it is these three key measures that we can use in daily practice to unlock many of the mysteries. I thank you very much for your time and attention.